So I'd like to welcome everybody to today's Experts Online session. Today we're going to be talking about a surgical workflow with AutoPlan, a new technology. And I'm really excited to have two expert surgeons with me today. I'm Nicholas Kroll, a project manager at Medel, and I'm moderating today. And what I'm so excited about is what we're going to see in the next hour. But I'm going to start with the basics. So the basics are, if I can get my slide working here. First, we're going to start with some simple tips. If you can name yourself, that helps us know who's in the chat and we can recognize each other, just like wearing your name tag at a conference. And please make sure that you're muted. That helps to avoid interruptions for us. And on Zoom, it's going to help if you close your other programs so that your internet's nice and stable. And lastly, and most importantly, your comments and your questions are very welcome. This is an interactive panel discussion. We're here to hear from you, and we've got our two expert surgeons. So if you have any questions or comments, just leave them in the chat, and we'll get to them at the end of the session, and we'll have a back and forth that I'm really excited for. Now, I'm happy to say that there's English live captioning. So go ahead and click closed captioning, and it'll be a little bit easier to follow along. And so now I'll introduce my two speakers. So I have Dr. Markus Pietsch from Helios Clinic Hildesheim in Germany. And I have Dr. Kristen from the University Hospital of Würzburg, also in Germany. And today we're talking about AutoPlan a little bit. But the real message is, how can we get individualized CI surgery? And how can we keep evolving CI clinical practice? So just because it's in the title, and I want to make sure everybody's on the same page, I'll go ahead and explain to us here what AutoPlan is, if I can get my next slide. So AutoPlan, just so that my other speakers don't have to give a full definition, it's a clinical software used for planning otological surgery, and it's got some exciting tools for audiologists as well. So it's a little bit like Google Maps for CI surgery. It's really exciting because it doesn't need anything fancy. It uses standard clinical imaging to immediately create really, really detailed 3D models for each patient's anatomy that you can explore, you can swipe through. You can get detailed measurements of the cochlea. There's a lot of exciting stuff, more than we could ever cover in an hour. And it's CE marked, so it's available in a lot of countries now. But beyond that, I'm going to let my surgeons show one of the most exciting parts of it, which is patient-specific individualization. And that's so important, because if there's one thing you take away from this, it's understanding that the human cochlea is so unique that variation in size and shape of those cochleas, it's relatively speaking, the human cochlea varies more than the human foot. And what that means is we'd all in this session have an easier time finding a pair of shoes that fits us all than we would finding one electrode that would fit us all. So this individualization, I think, will be an exploding topic in the coming years. But the takeaway I want everyone to have is seeing how these techniques could fit into their own practice. And so now we're going to go to a Mentimeter poll. So if you take out your phones and go to menti.com and enter this code, or you can scan the QR code. So what this is going to do is give us a little bit of a poll so that we can look at understanding a little bit of background from everybody. And we'll give everybody a minute to get there. All right, so the first question is, of course, to understand and react to the anatomy, we need to see the anatomy. So, simple question is, what is your pre-op imaging routine? Now, it might be different for children and adults, but it looks like a lot of people are using both CT and MRI, which is, I think, quite common. I think this is pretty good results already. It looks CT and MRI is pretty straightforward. So now we'll move on to our next question. So what I talked about here is adding new technology to your clinical practice. We want to be, from MED-EL, a supportive professional partner and not just come at you with whatever product or whatever technology there is. These things are only useful when they can really be spread, to as many clinics as possible, and especially functional and useful for patients. That's what we're really interested in seeing here, is how can new technology change patient outcomes? But as people can see, what's your biggest barrier? Let us know here. Simple description. Is it cost? Is it education on how to use it? Is it not being able to see a benefit? Is it that you already have a lot of different exciting things to look at? And yeah, IT, that is definitely a barrier with technology, because I know in a lot of clinics, there's a disconnect there. There can be regulations, but we'll just give a minute to see how people fill it out. Okay, some really good feedback here. Cost is one of the big ones, and I think that's important. If these things are exciting but too expensive to use, then it's a waste of time. But the good news is what we see today is something that's very affordable. And I think we've got a good list here. So I'd say we're ready to move on to the next slide. So today, my two speakers are Dr. Kristen Rack and Dr. Markus Pietsch. And I'd like to start with Dr. Kristen Rack. So Dr. Rack, whenever you're ready.
Yes, 1 second. So does everybody see my slides?
Yes.
Great. Yes. So at the beginning, thank you, the team of MED-EL, and especially Nick, for this nice introduction and for the possibility to talk a little bit about our expertise with this new tool, with the AutoPlan software. And I'm really happy that I and also Markus, we can show a little bit what we are working, what we're doing. So my talk in the beginning, I will give a little bit an introduction to the topic of cochlear length measurement. Then I will talk a little bit about the clinical application of AutoPlan software. And in the end, but also in between, I will talk a little bit about research, especially also with the AutoPlan software. So as you all know, there are different possibilities to measure the cochlear length. There is, on one side, there's a possibility to use the direct measurements. Then there is a possibility to use the indirect measurements. It's also called 2D reconstructions. Then we have the possibility to use mathematical methods, especially derivations from the spiral function, to measure the cochlear length. And last, the 3D reconstructions can be used. So regarding the direct measurements, their all first approaches are really old, or in the 19th centuries, people have tried to measure the cochlear length by this topic. And here, how does it work? You use histological preparations like cochlear sections, and then you use a micrometer to really measure around the cochlear structures. This technique has some advantage because it's possible to comparative measure in one preparation, like here, the area of the spiral ganglion and then the organ of Corti. And that maybe can help you also to determine other structures, like here shown the number of Hör cells per distance. But there's also some disadvantage because you have always shrinking artifacts due to fixation. Then the indirect measurement, they're also called 2D reconstruction. They have been firstly described by Guild in 1921. And here you measure the lengths between some structures in the cochlear on histological serial sections. And then these measurements are plotted, like here nicely shown in one of the first publications of Hardy et al. 1938 on a 2D way, and then here you can easily measure the length. That's really has an advantage because you can use high resolution measurements by microscope, or also here shown by photography, but it has also some disadvantage because you have often projection errors, because if you do not the cutting really precise, these projection errors can be up to 15%. Then there are the mathematical methods. They're all derivation from the Archimedean spiral function. And their first consideration using this have been published by Ketten et al. 1989, when they examined the ear of the dolphin. And here you use diameters of the cochlea, like here the diameter R or B, and then you use mathematical function. The advantage of these techniques are the easy measurements in histology and radiological imaging, but there are some disadvantages because there is an intrinsic error, because the cochlea is not a perfect spiral, and that's why and function cannot perfectly describe the cochlea. In the end, then there's a 3D reconstruction. They've been first published in 1989. And here you measure the cochlea in a 3D model around structures, like here shown at Dice et al. With this multi-planar reconstruction, or also nicely shown in this graph by Koch et al. From 2017, where they set the points around the 3D image of a cochlea. Here, the advantage is really that the height of the cochlea is included in the calculation, but there are also some disadvantage because it's really complex and it can be only performed in bony structures. So further on, I would like to talk a little bit about the expression cochlear length, cochlear duct length. I'm not totally sure if the term cochlear duct length, what we use at the moment, is quite correct, as a cochlear duct, as far as I learned it, really describes the scala media. And for us, it's more important, like here, the cochlear duct length, or in the other scalas, or it is really important. That's why to really define the location of the measurements, because the cochlear duct length at the lateral wall is different from the cochlear duct length as a basilar membrane, because the basilar membrane in the apical part and the helicotrema does not reach the whole length. Then the cochlear length in the organ of Corti is smaller. And then there's also cochlear length at the spiral ganglion. This is different. And then you can measure cochlear duct length at the place where you want to insert an electrode or post-implantation. So there's difference in the areas where you do the cochlear measurements. So how long is a cochlea? That really depends on the resolution of the data sets and the type of measurements. As I already said, there was one study by Alexiades at 2015 where they compared different, also older publication to do histological reconstruction. And they said here the cochlear duct length of the organ of Corti is between around 31 millimeters. And then there was a good publication by Koch et al. At 2017, where they used the synchrotron imaging, and they showed that the cochlear duct length of the organ of Corti reaches nearly 34 millimeters. And here at the lateral wall, it's nearly 40 millimeters. And also Daniel Schurzig compared in one of his publications different different techniques to measure the cochlear duct length, or to medical method the cochlear duct length. You can see the average, it's literally between 29 millimeters and 40 millimeters in the same preparations. If you sum up the most recent publication, there's a cochlear duct length is in the mean more or less 39.5 millimeters, and then the organ of Corti is 33 millimeters, but there's also, like Nick said, a big standard deviation. So shortly want to go through what is the AutoPlan software. It has already been explained. So it's a clinical software. It's developed by Cassination in cooperation with Medal, and it has several possible applications. You can use it to rapidly generate passive and specific 3D reconstruction from imaging. I will show some pictures later. You can use this then to visualize the individual anatomy of each ear of each patient, maybe also in in atresia cases, for example, you can visualize the temporal bone, the auditory canal, the auditory ossicles, the facial nerve, the chordae tympani, and this you can also use to plan surgical access routes. And from this, the AutoPlan software also derived, because the company Cassination has developed the first surgical CE roboter, and a similar software is also used in their system. And also the cochlea can be really precise evaluated. The cochlear depth lens can be evaluated pre and postoperatively. You can use it to a selection of electrode and determine the electrode contact position postoperatively with the respective frequencies. So which formula is used in the AutoPlan software? And in the AutoPlan software, the ECA formula is used, which it's a type of a mathematical function where the width and the diameter of the cochlear are measured. But there in the newer versions, also other specifications have been added, especially for measurement of the organ of Corti. There is an addition of 1.58 millimeters, because you know that here in the hook region, the organ of Corti is much more longer than here at the round window. And then the postoperatively, or the inserted electrode, the frequency and insertion depth can be measured, and then also postoperatively the frequency and the insertion depths. So there are in the, like I've just checked last week, there are here 6, but there are still more publications with the AutoPlan software. I cannot go into detail of the many, but I would like to show one picture, one graph, what I think it's really important. It is of one of the first publications from Antwerp, from the group from Grit Mertens et al. And they showed that they're using the ECA formula in the AutoPlan software. They have a really low intra and inter-observer variability. And in my opinion, that is really important for good software. Then it does not depend how often you do the measurement and who does the measurement. That should be nearly the same. So how is our concept of preoperative imaging in cochlear implantation? In adults, we perform in all adults an MRI scan and an MSCT scan. But in children, we have in Würzburg some different concept. We have a concept we use in all children, an MRI, and try to avoid the MSCT scan. We do that since the year 2013, because in 2012 there was a study published that if you expose children with radiation, there's a higher risk of leukemia and brain tumors. And that's why we changed in 2013 our routine. Before, all children received a CT scan, but since then only 13% of the children received CT scans, and there were most of the children where there was a suspicion of a malformation. We all also investigated if there's some risk in doing this, but we could not see any more complication in both the short and the long term. So how do we use it? We use, like I said, we use MRI and MSCT image. We enter the DICOM data sets into the software. In the beginning, we used an USB stick and the tablet with the AutoPlan software, but we changed now to a PC version where we have a direct input to the DICOM files, and then we do the measurements. Here the diameter and the width of the cochlea and also the height of the cochlea can be easily measured in the AutoPlan software. Okay, then after measuring the cochlear ductance, we insert from all patients the audiological data, and like here shown of this patient, and then we do a selection of the electrodes on the basis of the cochlear ductance and the residual hearing capacity. And we discussed a lot how far we should enter insert the electrode, and then we decide to use about 55 decibel this area, because in the case if we want to do an acoustic simulation in the higher frequencies, also if the patient would lose a little bit, there's still enough power of the EIS system to stimulate the cochlea acoustically. So we decided to use about the 55 decibel mark, and you can see here the inserted electrode. Afterwards, you get from the system a slide where it's shown where the respective frequencies would be if you would insert the electrode like perfectly. And you can see here the insertion depths in millimeters and also the hertz. Here, I would like to show you two possibilities of selection of electrode. Like in this patient, we choose the long flex soft electrode due to the fact that there was nearly no residual hearing in this patient. You can see here again the 55 decibel. And in this patient, we used a flex 26 electrode because there were a good residual hearing and we want to keep this in the patient, preserve this in the patient. We have implemented this AutoPlan software in mid of 2019, and then we have measured more than 250 cochlear with these tools. And in the end, we had about 50% flex 28 electrode. We had a 70% flex soft electrode, 5% flex 24, in 12% flex 26, and the standard electrode came out in 13% of the patients. Though that's a quite summary of all our inserted measured electrodes with the software. Now I would like to show you a short case of one patient where we use the AutoPlan software. So that's a young female patient with a progressive hearing loss. We did the measurements of the patient and we resulted in a cochlear duct length of 39.8 millimeters. And here now we have the audiogram of this patient, and this is now the frequency. So this is at 125 hertz. It's about in this patient at 35.7 millimeters. And then we choose in this patient the flex 28 electrode. And you can see here at 55 decibel, that's the area how far we wanted to insert the electrode. So afterwards, we get this the slide, which I've already shown, but which is shown which contact should go as far in. You see the most applicable contact should be inserted 27.3 millimeters with a frequency of about 600 hertz. Now, would like to show you a short video, especially of this patient where we used our hearing preservation technique, and here you can see that we really gentle open the round window at this patient. I hope the video is well seen. And then I try always to insert the electrode really slow. I try to take me at least 2 minutes of time. And I really say the anesthesiologists, they should tell me every 10 seconds and signal, so I use it so to insert the electrode, especially when I've inserted the electrode a little bit farther and have more stability, to insert it every 10 seconds, one contact. And in my opinion, that's a good possibility to control your insertion. Maybe I would like to speed it a little bit due to time. And you see now we are at about 2 minutes of video and the electrode has not been inserted fully. And after nearly 3 minutes, the electrode is then totally inserted. So I think that is really important, especially the speed of the insertion, because then you have little fraction inside the cochlea. Now, after 3 minutes, the electrode is totally inserted. I try to hold the electrode really tight so there's no movement. And in these cases, I always use all the titanium clip for the fixation of the electrode, because I think as easy the electrode slips in, it might also slip out. So I want to keep the electrode in place. Good. For postoperative imaging, we use a little bit other system. We have the possibility to use a flat panel volume tomography, and this gives really like great high resolution. We cannot use it at the moment preoperatively, only postoperatively. And you can see here that it is possible with this software, with this technique, to have like really low resolution of 200 micrometers. At the moment, we were possible also to use it in patient with 30 micrometers. So there's really a great possibility to reduce your resolution, which can help you to better look at this. And here is one publication of us where we compared this flat panel volume computer tomography, especially with a secondary reconstruction, and we could see that the cochlear duct lens here used another technique and 3D measurement of the technique. We can use the same values like in micro CT. So I think this flat panel volume CT has great advantages for use it, especially in the postoperative control. It is also possible to use it here to do 3D reconstruction of the human cochlear in high resolution. Though this is now a resolution of 0.5 of 50 micrometers from a clinical flat panel volume CT, and that's approved this system. So we are quite happy that we can use this and do our postoperative measurements with this. We have also just published a paper where we compared this flat panel volume CT in the AutoPlan software, and you can see here another possibility of this technique. It's much better to determine the electrodes and to measure then the different distances between the electrode. Although measuring the cochlear duct lens preoperatively, we have like a higher cochlear duct lens compared to the MSCT, and also the variability of the inter-electrode distance was much lower with this flat panel volume tomography. So I think that this is a quite good system to use it, and especially use it in the AutoPlan software. Now you can see here from the patient, the postoperative scan of one patient, and how the AutoPlan software then determines the postoperative contacts. And now I want to go back to our case. Postoperatively, here we did a measurement of a little bit shorter cochlea, but here you see then the postoperative audiogram. So I could keep the residual hearing of this patient completely, and now back. And here also the electrode contacts of the patient are now visualized. I'm not sure why here not the electrode is shown, but only the contacts. But here it's really well seen that the highest contact is still in the area of 55 decibel, and here the hearing of the patient could be preserved. Postoperatively, you then get also this frequency map, and here you can see that the contact number 1 has been inserted a little bit deeper, 29.1 millimeters with this hertz. And now it's also possible to enter this data in the Maestro fitting software. You can enter the data with the organ of Corti, mathematical calculation, and also with the spiral ganglion calculation. And at the moment we are a little bit working how we should use these contacts, which are here out of the range of the fitting of the Maestro software, which is about 8.5 kilohertz, with the spiral ganglion as a calculation that fits much better. And we are having 2 studies at the moment where we want to investigate this too. So at the end, I would like to shortly talk about MRI and AutoPlan software. There's also one paper which has been recently published, and there they compared MSCT and MRI in this software, and they could show that there's really less in most of the investigated MRI scans. There is less difference compared to the MSCT. So that showed that this technique can be, also the MRI can be quite well used with the AutoPlan software. Here I would show a short second case of a children where we use the AutoPlan software to do the measurement of the cochlear duct lens in the AutoPlan with MRI. And You can see here the patient has no residual hearing, so we selected a long electrode, Flex 28 electrode fitted well into this cochlea, and you can see then here the contact numbers of the organ of Corti and also the spiral ganglion. Postoperatively, we do not perform in children and CT or MSCT or flat panel volume CT scan yet because of still this radiation problems. So I cannot show any postoperative results with the AutoPlan software. What are we working at the moment here? We have also the possibility to really use a new MRI technique with a high resolution, lower resolution of 0.3 millimeters about, and we have also tried this in the AutoPlan software, and you can see that it's in this technique, it's much easier to define the outer wall of the cochlea, what you need for the measurement in the software, and I think this will also be of an advantage. At the end, I would like to show you some pictures of the middle ear segmentation. We try also the different imaging possibilities, and you can see here with a 99 millimeters flat panel volume CT, you can have a much better automatic segmentation of these ossicles performed by the software. And another study where we are trying to evaluate how well does the software measure the calculated frequencies. And here this shows also that by higher resolution, it is much better, the calculation of the respective frequencies. So in the end, I would like to, at the beginning, thank my team, especially Dr. Müller-Graff and Dr. Völker and Dr. Kurz, which have contributed to my talk today. Dr. Völker and Dr. Müller-Graff are also residents and staff members of our clinic, which have done a lot of this AutoPlan investigations. And like, as I showed, AutoPlan can be really well used to the preoperative imaging, but or the postoperative imaging and analysis of the cochlea. It can be used to automatic segmentation. You can use it in MRI, and also research with the software is possible. Thank you very much for your attention.
Perfect. Thank you very much, Dr. Rack. I think that was fascinating. And if anybody has questions, please drop them in the chat. But right now, we're going to go over to Dr. Markus Pietsch. So, Dr. Pietsch, take it away whenever you're ready.
So, hello, everybody. I will contribute to this Experts Online session, my cochlear implant surgical workflow with AutoPlan. And well, Kristen already showed a lot of the possibilities we have with the AutoPlan software. I will try to give maybe a view to the future, what might come, and add a few things that are still open. Well, first, why do we measure cochlear duct length? And we already heard a lot about the variability of the human cochlea. And we studied in the MHH, so Medical School of Hanover, this topic in corrosion cast of human cochlea. And these are images from a very nice presentation we published in 2017 about this very brief measurement of those corrosion casts. And it was a collection of 108 of those corrosion casts that Peter Erfurt did for many years. And what was very interesting,
can you wait for a minute?
Those corrosion casts in very brief and very reproducible ways. We saw special things you could overview very easy if you look at only one of those corrosion casts. But if you look at many of them in the same view, you find special things. For example, cochlear indentations for example, at this place where the facial nerve passes the basal turn of the cochlea, and this gave us the possibility to state that the spiral form of the human cochlea results from spatial constraints, and you see that the facial nerve, the tensor tympani, the carotid artery, there are a lot of structures around the cochlea, and we believe and we are very sure that those surrounding structures are highly important for the variability of those cochlea. But for our topic today, I will show you those measures we did, and you see here very well that we also found this described variability of the cochlea, the metric length. We found here in those 108 corrosion casts a mean of about 41 millimeters, plus minus 2 millimeters. The angular length also varied a lot, so about 967 degrees, plus minus 45 degrees. And it is very interesting if you look at the so-called B ratio. So you have the diameters in the basal turn, the A value and the B value. And if you look at the different quartiles of the B value, so where the B measure, the B diameter is intersected by the modulus, you find different quartiles, and in those quartiles you will find very different cochlear profiles from the ascending of the cochlear duct in the height direction, and so in the first quartile you find a kind of roller coaster profile. So there is a dip in the turn of the cochlear duct at the point where it so-called deep dives down and then climbs up on the second turn. And if you look at the fourth quartile, you don't find this roller coaster. There's a kind of sloping profile. So there's these different variable portions of the cochlea. You find different profiles of the cochlear duct, and this might be very interesting for insertion forces and for destruction you might find when inserting an electrode into the cochlea. And because you can imagine that the roller coaster profile is way more dangerous for insertion forces and for destructions if the electrode tip is guided towards the basilar membrane. Another finding we saw very well was that you cannot describe the cochlea as a logarithmic spiral. We found a very better residuals if you use a polynomial spiral model. So this explains why the metrical models that base on a logarithmic spiral model will not function that well because the cochlear spiral is not a logarithmic spiral, it is a polynomial spiral. And if you use those polynomial models, you get better results in the prediction of the cochlear form and cochlear length. I want to show you those models. You can download them. I will just go to Safari. You find on the website neuroprosthesis.com. I don't think, no, you see neuroprosthesis.com. And here on this website, this is the website of Professor Kroll. And here in the section Cochlea, you will find this Cochlea model, and you can download it. It is freely distributed, and it is well described how to download it, how to get it working, and how to use it. Now back to the presentation. We have now just published this year improvement of this model. Daniel Schurzig, who's also in the audience here today, I'm happy about that. We published a new model that is an improvement of this former model, and you can see here the model is programmed in a visual software that you can download, and you can use this software to calculate your own predictions from measures you get from your clinical CT or MRI. And what you need is just the A and B values, but you not only need the A, but the intersection of the modulus. So you need the radius, so radius 1, radius 2, radius 3, radius 4 of the basal turn of the cochlea. And if you put those values in the software, it will give you a three-dimensional model of the cochlea. And the gray line, it is the Pietsch model, and the black line is the new RS model. And the thing is that the RS model is way more accurate because it has more degrees of freedom. So it can describe the spiral form of the cochlea way more precise, because the degrees of freedom allow to follow the real path of the cochlear spiral way more accurate than the model did before. And you can see that in if you compare the different models, and you see the ECA model, this is the model that is actually at the moment the base of the AutoPlan software. And you can see that the new RS model is in all things more accurate than for example, the ECA model. And the problem is most models work quite well in the basal turn or in the second turn. But if you go more up to the tip and you want to have a prediction of the whole length of the cochlea and the length of the cochlea at the tip, you see that the old model, for example, the SQD model, works way worse in prediction because it has less degrees of freedom. So the SQD model is here the blue line, and the black line is the real slope of the cochlea. And you see that the new RS model follows the actual parameters of the cochlea very well. And we hope that this RS model might be the engine of future AutoPlan versions. We will see. So the AutoPlan software has been shown in detail by Kristen already. So I will just add a few things. Here in our clinic, we use high resolution imaging, flat panel volume CT for preoperative and postoperative measurements. And we have the possibility to scan with a very high resolution of 150 micrometers. And I think what is quite interesting or important to state is that you should standardize your windowing parameters so you can compare really well the different measures, because you know the windowing parameters have a high influence on how you measure the borders between the bony and the soft labyrinth. Well, then for our workflow, of course, we for the electrode choice preoperatively, we use a lot of parameters. We look for the history of the patient, how's the progression of the residual hearing, what is the cause for the hearing loss, trauma, meningitis, labyrinthitis, is there any genetics that might have an influence. Then we look, of course, at the audiometry, speech test results. Is there any usable residual hearing? Then you should look at the imaging. You should also look for malformations. Is there, for example, a large vestibular aqueduct that might be prone to gusher? And of course, then we use AutoPlan. In the beginning, we also had this tablet, but now we have this desktop system with the direct PACS input. This is a big improvement, and I think it's also way more. The handling is way better on a big screen with the mouse, and I think you can do a more accurate measures with this. So for patients without any residual hearing, we try to get a target frequency for the most apical contact of about 250 Hertz. And you see here is an example. If you have this patient, for example, with a 32.7 millimeter cochlear duct length, the predictions for the different electrodes can be given. And in this case, we would look for example, the 28, flex 28, because we want to be at around 250 Hertz. You see that in this case, the step from the 28 to the next longer electrode is very, very big. So you have a target frequency for the most apical contact with the flex soft of 86 Hertz. And the angular value between those predictions is 120 degrees. So you have almost between quarter and a half turn longer or deeper insertion. And you should always keep in mind that this wrapping factor, so how strongly the cochlea is wrapped for the cochlear duct length, is also a factor you should keep in mind, because it will increase insertion forces and might also be a cause for not being able to insert an electrode completely, and you don't want to have contact out of the cochlea. Another check, you should always see if the round window is the accessibility of the round window is well. So the facial nerve is not very limiting the access of the round window. It might be harder to insert a longer electrode at a very worse access to the round window. So in those cases, you might also go for a shorter electrode if you are at the decision between two electrodes. Of course, in EAS patients, you should always look for the hearing aid, if it's possible for the patient to wear it. For example, if the patient has a lot of otitis, external otitis, or any ear canal problems, this might be also something you should keep in mind. Post-surgery counseling, we also should, after the implantation, we should do a kind of quality check. You should always be recapitulating your intraoperative findings. How was the accessibility of the round window? Did your preoperative predictions meet what you found intraoperatively? How was the medical condition of the cochlea? How was the handling of the electrode insertion, the forces, was it possible to insert the electrode fully, and the telemetry. And after surgery, we always do visualization of the implant and electrode position, just for us to measure, of course, the insertion of the electrode and the electrode contact for the anatomy-based fitting. But also, I think it's very nice for the patients to see what is now inside the head. And then we always check for the preservation of residual hearing. And I think you should always do this quality check and always recapitulate what were your predictions, and did the intraoperative situation meet your predictions? Because you should always constantly question yourself, constantly challenge yourself. So now I have just an example, 3 patients, no usable residual hearing in all those patients. And that's very interesting. You have, for example, here 2 patients with very, very similar cochlear duct length. But you see that predictions of the models can be quite different. So if you look here, the patient with a 32.2 millimeter cochlear duct length, we choose the Flex 26 electrode. This is so the prediction for the most apical electrode contact, for the frequency, for the insertion angle, and for the cochlear coverage. And you see that the post-surgery measures met the predictions quite well. In this patient, we choose the Flex 26 because we wanted to be about 250 Hertz. In this patient with a slightly longer but very, very similar cochlear duct length, we had to choose the Flex 28 because the 26 would have been too shallow, for my opinion. And in those 2 patients here, you see the cochlear duct length is very different. So we have a way longer cochlear duct length. And in this patient, we choose the Flex Soft electrode. And in the end, the post-surgery, the position of the electrodes were very similar, and we were able to get the implant in the position we wanted it to have, although we had to choose very different types of electrodes. I think this shows very well why we use an AutoPlan to have an individual approach to get the optimal position and the optimal electrode for our patients. And here is just 2 add-ons. With AutoPlan, you can also measure the bone thickness, which is important, for example, for the bone bridge. You can set, for example, a threshold for the bone thickness, and it will show you where this threshold value is possible. And you see here in the temporal segment of the bone is too shallow. So if you put, for example, the bone bridge in this place, you would have to expose the dura. And if you put it in this place, you won't have any problems to insert the bone bridge. And you see here, here is the post-op image, post-operatively, we placed the FMT just in the position we wanted it to have. And you see here the dura and the sinus were very well preserved. And another point, I think it's very good for teaching. You have a very detailed 3-dimensional visualization of the inner ear or the middle ear structures, and you can segmentate the key anatomical structures. And it's very good for residents and for students to have an insight in the anatomy of the ear. So now I'm at the end of my presentation, and here you can see why cochlear implants make your eyes shine. This is an actual image of my own head. Thank you very much.
Excellent. Thank you very much, Dr. Pietsch. And I really like that last image And it's also, I think, really representative of why we work so hard to always drive new technology, because CI users now are operating on a level that couldn't have been imagined, I think, 30, 40 years ago. So, I mean, right now, you've got bilateral implants, and you've got through this whole session, no problem at all, getting through a year of switching to fully online Zoom. It all works out, right? So I've got a question in the chat from Michael Paco for Dr. Rack. So Dr. Rack, Michael wants to know what the effective radiation dose and the absorbed radiation dose would be for the flat panel CT compared to the other CT.
Do you hear me?
Yes.
Because yes, that's a good questions. Like there are some studies out which have investigated this flat panel volume CT system. It's a system of Siemens Healthineers, and they showed that it's equal or even less compared maybe to a 128 MSCT. We have done some our own measurements. We could show that there's like dependence which scanning protocols you use. So within the system, there are scanning protocols, I think 3, 6, 10, and 20 seconds. And there is better better visualization with the longer protocols, and in the 20 seconds protocols, in our measurement, it's a little bit higher than our MSCT protocol. But during all these measurements, we came out that our MSCT protocol is really radiation reduced. So it's more or less the same. We're looking forward. We are getting a new angiographic system, and then this 20 seconds protocol should be done in 3 seconds, because I have to admit, with the 20 seconds protocols, especially for the patients postoperatively at the first postoperative days, it's quite difficult to hold the air for 20 seconds, because that's needed for a good scan, especially also in the hearing impaired patient. They sometimes also have problems to understand this, but I hope with the 3 seconds protocols, then it won't be a problem anymore.
Perfect. And I know we're running low on time
Thank
here, but I think I'm getting a cue from my moderators. We want to do a group picture. So if everybody can turn on their cameras, we would love to follow through with our tradition of getting everybody on the cameras here, and we'll take a quick group picture. So on the count of 3, everybody say individualized cochlear implants. Perfect. All right, I've got it. So we've got another question in the chat from Dr. Lee, I believe, that is, how do you access AutoPlan? This is a really good question. The simple answer is contact your Med-El representative. You can also write to us in the contact form, but it's something that's already available in countries accepting the CE mark. So it's been on the market, it's available. And I saw cost was one of the barriers before. It's quite affordable. I think this is something that is, if what you saw today looks interesting to you, these things are very accessible. Does anyone else have any questions? I think we're almost perfect on time, but I'd be happy to take any more questions. Well, if not, then I want to thank everybody. Well, I have one more question in the chat about what accuracy is needed for CDL. I think I can answer that just for a practical sense for what electrodes we have available. The ECA model in AutoPlan is perfectly functional. Dr. Pietsch, your model is especially better past 720.
Yeah, it's better for the prediction of the whole length of the cochlea, and it is getting more important now as we want to do anatomy-based fitting, because for the Greenwood function you need the real length of the whole cochlea, For the basal turn or maybe second turn, the older models give a very well prediction. But if you want to go for the whole length of the cochlea and especially go to Greenwood, you need models that give a better idea of the whole length of the cochlea. And you know, Sumit Agrawal, Professor Sumit Agrawal in Canada, he did very high quality synchrotron imaging of the helicotrema, and is also looking for the hook region. And I think we will get some more information on those two black ends of the cochlear duct we have at the moment, and to get a better idea of the real length of the cochlear duct, especially to get a better prediction for the Greenwood function. Yeah.
Excellent. And I would say that puts us right at 1 hour. So I want to thank everybody for being here. This is actually our 1-year anniversary from starting this. And so I think it's been a fantastic year in terms of Experts Online. I know it's been a challenging year in many ways, but we've had a great time bringing people together online. We've got another session coming up in 2 weeks, and that session is going to be about atraumatic deep insertion and how you can have hearing preservation with long arrays. And the last thing I just want to call out, if I can get my next slide, before I let everybody go, is you can watch all of these sessions on the Med-El Academy. So all of the recording of past sessions, the recording of this session, there's so much fantastic information on the Med-El Academy. That's academy.medel.com. You'll find excellent presentations on so many topics, and it's all free. So please check that out when you have time. And we really look forward to seeing you for the next Experts Online sessions. Have a great day, and thank you for joining us.